Hello, everyone. I'm Dr. Jeff Turnbull. I'm the Medical Director of the Ottawa Inner City Health Initiative, and I'll be your moderator today, and I'll also set the context a little bit for us. The session is entitled COVID-19 and Homelessness, Protecting Our Most Vulnerable, and we have three other panelists who I'll introduce just before their individual speech and presentation. But our goal today is primarily to give a context of what homelessness is like and the challenges that are faced by individuals who are experiencing homeless, especially in the context of COVID-19. Talk about what the literature tells us about homelessness, and then think about short and long-term strategies to mitigate the risk that these individuals are exposed to on a regular basis. This is part of a larger initiative that is a national initiative that is preparing a policy brief to the Royal Society. So we'll look forward to your comments now and throughout the presentation, but also later to see how we could better improve our report. So firstly, let me set the context, and then I'll turn to my colleagues and introduce them specifically. So the context about homelessness is, I think it's important to recognize obviously it's a fundamental societal challenge. It is very hard to define. It's a diverse population. It's diverse in terms of the different sectors that are responsible for services directly or indirectly in the community. So that would be services such as public health or acute care, but also social services, shelter-based housing services, municipal services. So it's a complex environment for which to participate in trying to serve these challenging individuals. The individuals themselves are from a diverse perspective. It's no longer the domain of the adult male. We see many women in this context, but we also see families, we see the adolescents, we see the elderly, we see individuals who are newcomers, and we see individuals who are Indigenous. So it is a diverse population. Finally, it's not just confined to the urban setting. Homelessness is a challenge that is faced by small, medium-sized communities right across the country, rural, remote settings, and Indigenous reserves. So it is ubiquitous, but it's heterogenetic and very diverse. So what's the size, though, of this challenge? The size is that approximately 230,000 individuals every year experience homelessness. That's about 35,000 individuals per night. So it's a massive number of people that have grown over the years, especially since the last 3 or 4 decades as a result of funding changes, economic imperatives, and changes in social services. And so we've seen the homeless population that we currently know grow and expand in number and complexity. As you also think about this, it's not just the homeless that are challenged. We're not even talking about the unstably housed, those people living in unsuitable housing or unaffordable housing. So it's a complex setting, but we have chosen to restrict our comments principally at this point in time to the urban setting of urban homelessness. And so in that context, we see, the majority of people stay for very short periods of time, but the chronic homeless, those that represent about 15% of the homeless population, they stay a very long period of time. This is their housing, and they consume they consume a very significant portion of resources. So the chronically homeless, if you think of them, there is a high prevalence in this setting of mental health challenges, addiction challenges, and physical health challenges. And they're isolated, they're in a high-risk environment, they lack access to reasonable entitlements that you and I would expect, such as healthcare. And so as a result, they suffer very significantly in terms of their poverty and circumstances, and they pay that with their health. And lastly, before I turn it to my colleagues, I think that everybody, at least for someone who's been working in the shelter environment like myself, we thought that things probably couldn't get much worse when crack cocaine came on the environment. And I should have never said anything about that, because the next thing you know, we had crystal meth and we had opioids. And I think the challenges that we face in this environment have become so much more prominent with the advent of the toxic drug supply and overdose deaths that the homeless face. So in that context, then, we had the prevalence of the beginning of COVID. And COVID came to us probably, and we were not well prepared. We did not have a coordinated action plan for a pandemic response. And if you think of the usual public health recommendations as it relates to the pandemic, that would be to socially distance, to practice hand hygiene, mask, test when you have symptoms, and then isolate. Well, in our context, in the homeless world, almost every one of those are impossible. Today, for example, in my setting in Ottawa, there's 1,000 homeless people. There's a room with 70 beds in it. Those people generally do not wear masks. They suffer from significant mental health and addiction challenges. They're vulnerable as a result of their coexistent medical problems. And they lack access to reasonable treatment. And should they have symptoms, which is very difficult sometimes to discern, because about 20 to 30% of my population have cough and shortness of breath anyways, should they have symptoms and should they be willing to be tested, then where would they be isolated? There's no isolation facilities for them. And so these were the challenges that we faced in a complex environment, trying to ensure and protect the homeless from what we thought was going to be the inevitable consequences of the pandemic. So I'm going to stop at that point in time, and I'm going to turn it over to our presenters, and with that setting. So the first presenter is Stéphane Burrell, and he's going to speak on the systematic review of outreach, prevention, and mitigation strategies in the shelters. And Steph's research focuses on characterizing and addressing individual, network, and structural determinants of infectious diseases among marginalized community. He's an associate professor at the Department of Epidemiology and International Health at Johns Hopkins School of Public Health. So I'll introduce the others. We'll hear from Steph. If there's any significant points of clarification you need, we're happy to hear them, but I'd prefer to hold any questions towards the end after the presentation. So use your chat line and a few other things like that. So Steph, thank you.
Thanks very much, Jeff. So yeah, just for context, although my academic home is at Johns Hopkins, I provide care in the shelter system and have for a number of years in Toronto. And with Thomas Love worked on this, our initial recovery site for folks experiencing homelessness. So just in terms of the connection to the work here. So indeed, as you know, going back to when Thomas Love and I, back in sort of mid-March, or when the first day cases started popping up in Toronto, we're thinking about how to set up an appropriate site and appropriate resources for people experiencing homelessness. We turned to the literature, as many of us do, to try to inform the development of that site. And I think what we realized kind of early is that there is a bit of a mishmash in literature, and we really felt like, you know, this opportunity through the Royal Society is such an important one, but also thinking about getting, you know, some form of a systematic review out in order to ensure that, like, when the next pandemic hits and the continued waves of this pandemic, that there are resources that people can turn to in more rapid ways and more and more easily use in their own settings. I think, you know, Jeff's already spoken really eloquently to like why the needs are, or why the needs for, particularly needs for homeless communities exist. It was clear from SARS Part 1 in 2003. It's been clear from invasive fruit-based strep outbreaks that many of us know about over the years, influenza outbreaks, tuberculosis, that the folks that are living within shelter settings have particular risks for outbreaks that are not shared amongst others living in private dwellings. And you know, we've all sort of collectively think about how to mitigate those. We wanted to you know, sort of like see if there was, you know, sort of like best practices that we could turn to. I think Jeff also spoke to, you know, the significant amount of comorbidities that exist among the communities that we aim to serve, and then just by nature of the living arrangements. So the question that we asked was, the sort of title of the review was a systematic review of COVID-19 mitigation strategies. We registered this in Prospero, so you can also share the link for folks if they are interested. The goal was to identify what are the optimal prevention mitigation studies or publications that exist. And so the population that we included were folks that were homeless, defined as having no fixed address, or who rely on temporary accommodations, including institutions and shelters. We were seeking particularly interventions, and this was an intervention aimed at mitigating the effects of a communicable disease in the context of an outbreak. And so that was really the goal, again, within the homeless sector. So the rest of the PICO question was about ideally having a comparison group, and the outcomes that we were seeking for: reductions in disease prevalence or incidence over time, reductions in mortality, and uptake of adherence strategies. And so even if they hadn't seen, for example, the improved public health outcomes or individual level health outcomes, that they'd seen good uptake of the particular intervention that had been put forward. We also were interested in cost effectiveness, in addition to quality of life of folks that were included in the studies. We had a broad-based search, and so we included multiple different databases, and we did this using like a PRISMA compliant search. And so the preferred reporting in systematic reviews and meta-analyses. And so everything was done in duplicate. We used Covidence, which is a nice tool in order to pull information out of the databases. All abstract and full screening was done again in duplicate by 2 medical students, which reminds me to thank all the folks who are part of this. So I'll just say, you know, we started out with a number of, you know, over 3,000 different potential titles. I think it's striking how little we whittled ourselves down to. So in the end, we had 24 articles meeting inclusion-exclusion criteria, 11 of which were related to COVID-19. And I'll note, we went back 15 years. And so, you know, 11 of which were related to COVID-19, 7 of which were related to tuberculosis, 1 which was related to H1N1, and then there was 2 related to sort of broader, one about acute respiratory infections in general, and another one more broadly focused on infectious diseases. 18 of the studies were from the United States, 4 were from Canada, 1 was from France, and 1 was from South Africa. So not a lot of geographic representation. I will note we focused on English language publications, but nonetheless, normally you would expect a broader representation than just that. The majority of these, again, were from south of the border. I think, you know, a few key things that have really emerged is that actually only 1 of the studies was truly an interventional study. And most of these were either cross-sectional, observational, either, you know, again, cross-sectional or prospective, where you're following people over time. There were sort of 2, and the evaluations were accordingly not like, you know, we found no, for example, randomized designs. We found no experimental designs in general. Most of these were not, you know, obviously were non-randomized designs with sort of, you know, pre-post evaluations. There was 2 key intervention strategies that were the most commonly used. The first one was setting up screening within shelter settings. So this is generally screening for tuberculosis, but as well in the context of outbreaks, they've had screening for influenza, and rapidly for the COVID-19, the screening for COVID-19 within the shelter settings was seen as a common strategy, including one that we used here in Toronto. And the second key intervention approach was really a development of isolation sites. And I think, again, something that we've recognized as being important that many of us did across the country, less so actually in other settings, but across the country to try to protect folks, was setting up facilities where folks could voluntarily go and coalesce and sort of ride out their potentially infectious period before returning back to the shelter setting. I think what struck us though in this was just like how little study there has been. So I think for those of you who have also looked at the literature, for example, around long-term care facilities, there's hundreds of articles that have evaluated interventions, and there's dozens of randomized controlled trials and larger scale studies. I think it is striking that the only intervention study that we could find here was a pilot assessment of hand hygiene within Skid Row in Los Angeles for folks experiencing homelessness. There has really been very limited investment in research affecting and trying to improve the needs of homeless communities. And I think, the sort of end result of that in many ways, as we're sort of like pulling together the results of the study and making the case about what there is that we were ill prepared for COVID-19. I think we'll talk about like all the things that the few of us here and so many others obviously who are not on this call or are not presenting have done to try to serve folks and work with folks experiencing homelessness across the country. But we're ill prepared because of a very limited evidence base that exists, and I think related to very limited investment in improving the needs of folks experiencing homelessness across Canada and I think more broadly across many different countries around the world. And I think that should be sort of a call to action for funding agencies and others to also think about the fact that like we don't know a lot because there's not been a lot of research, and often that's not because people haven't tried. I think in many of us know folks that have been trying to do this work for many years, and there just is often less of an appetite to invest in research for folks experiencing homelessness. And I think as a result of that, there's also a lot of like mistrust within the homeless sector about any research, because it's just not sort of part of like learning is not a large part of the agenda. So I think with that, I'll finish. I want to note this work was done by Alice Zhu and Eva Bruchetta. Alice is a medical student at University of Toronto. Eva is a medical student at Queen's University. Tomislav Svoboda, who will talk later. Aaron Orkin, who along with Tomislav and I are part of the population health team at the Inner City Health Associates in Toronto, and myself. So thanks for the opportunity.
Thanks, Steph. That was fantastic. The next speaker is Monty Grosh. Monty is an internist, addiction specialist who has one foot in Calgary by the seams of things and one foot in Edmonton as well. And he's with the University of Alberta Hospital and works as well with many community organizations helping and providing support for marginalized populations. He's an assistant professor at both the University of Alberta and Calgary, and has advised the Alberta government on policies pertaining to responding to COVID-19 in the homeless sector. So I'll turn this over now to Monty. Thank you, Monty.
Well, thanks, Jeff, for having me here. And I first want to say thank you so much for allowing me to present our key recommendations from our report. I want to acknowledge these individuals here for their contributions to making this report happen. And this is my disclosure slide. So our recommendations are very much reflective of these key issues that impact the homeless population. And Jeff kind of alluded to this before, but our population is very mobile in nature. They use multiple different services and sites at any given time. There's a crowding situation that occurs within our shelter spaces. There's challenges with physical distancing. A lot of our clients are asymptomatic or have baseline symptoms that might be consistent with COVID. They're also unwilling to use face coverings at times, and there's also increased mental health and addiction concerns. So our very first recommendation is that an effective COVID response for the homeless population should be centrally coordinated, locally delivered, flexible, and integrated between diverse populations and partners, and data informed. And this was something we experienced very early on in the pandemic. We needed a centralized coordinating group that consisted of key influential decision makers. And these can include ministerial bodies, include municipalities, includes public health and health services, as well as people with lived experience and shelter providers themselves. And they are key to making this happen. And we also need to establish clear roles and responsibilities. One thing that we also noted in the Alberta response, for example, is that no one really knew whose responsibility was what. And pre-planning was key to avoid this from happening. And we worked through it, but it was a difficult process at first. The second recommendation is that special attention must be paid to service providers and shelter staff to ensure that they and the clients that they serve are safe, informed, and included. So again, service providers are key to the pandemic response. They are frontline agents in dealing with COVID-19. We need to provide them with PPE and protection. We also need to determine what can happen if a service provider needs to go into isolation. So we need to respond to this, and by having cross-training of current employees, hiring temporary employees, identifying critical job functions within the shelter sites to plan for alternate coverage, plan for surge capacity, surge staff, and ensure that they have PPE, and plan to have symptom screening as well as mental health supports, because many of our frontline workers will get burned out during this process. And we need to screen for that. We also need to have a reduction. We need to determine which staff need to stay on site, as well as which staff should stay off site. And this is mainly because staff can be a conduit for introducing COVID-19 into the sheltered environments. Our third recommendation is that shelters must be informed of and implement infection prevention control recommendations. This is very much reflective of the local context and local recommendations from your own local IPAC. This includes cleaning and maintenance plans, providing PPE and masks for clients, how to maintain 2-meter physical distancing, and education to clients. This is very important about what COVID-19 is and why it's important to have certain protective measures in place, including masking and hand washing. One thing that we've done in Alberta is the cohorting of clients in groups of less than 15, and this helps with contact tracing as well as isolation, should isolation be required. And then last but not least, limiting interfacility transfer, interfacility movement. We know our clients move back and forth between various different service agencies, and we want to avoid having multiple sites go into outbreak simultaneously. Our fourth recommendation is that shelters in conjunction with housing partners must immediately deal with the challenge of overcrowding. Crowding is inevitable in these sites, and we need to take care of this. And by far our first priority should be to house these individuals. Housing is by far our most effective strategy, our long-term most sustainable strategy, but it is an expensive strategy, and that's not always available to us. So if that's not available, we need to have an alternate space to decant these individuals. Private living spaces are by far, should be prioritized. So this includes private hotel rooms, private apartments, but again, that will not be possible due to budgetary constraints. And if that's not the case, then congregate living spaces can be considered. And this might be ideal for certain populations. A lot of our clientele tell us that they feel institutionalized if they're by themselves in their own hotel room. So this can help mitigate that. One thing to stress is that encampments are not a viable option for overcrowding. We should not be suggesting that clients go into encampment spaces. That being said, in Alberta, we do have clients who are very scared of going to the shelters right now and therefore choose to stay encamped. Recommendation 5 is that as services and delivery models change during the pandemic, they should be appropriately redistributed to areas of increased need, being cognizant of historical trauma. All of our service provisions needs to be appropriate and trauma informed. We need to provide additional services regarding harm reduction addiction. Right now, we're facing a concurrent epidemic of the opioid crisis. And so therefore, we need to address this as well and continue to provide services that address this situation. And then last but not least, we need to have a max vaccination program for all no fixed address clients. And this is predominantly with H influenza right now, because the symptoms of H influenza are very similar to COVID-19 baseline symptoms. This can include the pneumococcal vaccine too. And then last but not least, we should prioritize this group when we have the COVID-19 vaccination in the future. The 6th recommendation is that we need to develop and put in place evidence-informed outbreak management plans for all facility providers supporting the homeless population. Because of our crowded spaces in our shelters, it's inevitable that a mass outbreak will happen. And the key here is to be prepared as much as possible beforehand. And this is very much reflective of the first recommendation. We need to establish clear roles and responsibilities and a central coordination plan to manage an outbreak situation. We need to establish clear lines of communication to manage the outbreak, create a systematic approach for contact tracing, and last but not least, educate frightened clients about what an outbreak means and provide supportive guidance and continued support as they manage through and deal with this pandemic. So our population and COVID-19 in general, like the key here is for screening. And then if you do test positive or you might have come in close contact with a COVID-19 individual, you need to self-isolate. This is no different than the homeless population. So our 7th recommendation is that for those homeless who cannot safely self-isolate, we need to create isolation sites for those awaiting test results and those who test positive for COVID-19. These sites should typically be off-site if possible, outside of the shelter space, but that's not always possible, of course. And we need to have a tailored approach to managing these clients while they're in isolation. Because these clients transition from community into these isolation facilities and back into the community again, we need to have an appropriate system of intakes and discharges so that there's a smooth transition of care. We also need to have trigger points for scaling up and scaling down. We know that sometimes these rooms are not overly occupied, but at times when there's a surge in cases of COVID-19, we need to have increased capacity to deal and accommodate these clients. Last but not least, we need to have special services and consideration of special services for these clients. And these include palliative care, contingency plans for clients who are not willing to self-isolate, addiction mental health supports, harm reduction supports, and of course, by far, trauma-informed care. The 8th recommendation is that we need to establish and implement screening, testing, and contact tracing strategies that are evidence-informed, flexible, and applied consistently. Screening is by far key to protect this population group, and it should be occurring at outside of the shelter spaces, for example, within the shelter spaces. In Alberta, we have a sentinel surveillance policy strategy where we randomly swab random clients to see if they potentially have COVID, if they're asymptomatic or even or symptomatic. And screening should include a review of key COVID symptoms in keeping with up-to-date provincial guidance. Here's an example of what we're using in Alberta. We have a 2-parter for this. So the first screening tool is used by regular shelter staff. It doesn't need to be medically trained staff. So they screen for symptoms and they also make sure that there's no close contact of clients with someone who is COVID-19 positive. If any of these are true, if they have symptoms or if they come in close contact, they get taken to a separate location within the shelter site. And a secondary staff who has medical experience then takes over. And they do additional screening to make sure the client is okay. And they contextualize the screening. Many of our staff, as Jeff had mentioned, do have baseline symptoms of COVID-19 because they have a chronic cough or they have bowel issues. And so this needs to be taken care of and sort of contextualized to ensure that they truly are potentially symptomatic for COVID-19. Our last recommendation is that we need to establish culturally sensitive and trauma-informed approaches to a wide diversity of individuals who reside in the homeless community. The homeless population is heterogeneous, as Jeff had mentioned. It includes individuals who are elderly, youth, indigenous groups, LGBTQ, women facing domestic violence, homeless families, rural populations, and ethnic and refugee populations. And we really want to be reflective of this, especially the indigenous populations. And so we want to engage and help them participate in the response that's appropriate for them, their circumstances and their perspectives, using the circumstances, understand the circumstances and using the perspectives. That is key here. We really, again, want to be tailoring our response to the needs of the individual and the population group. And with that, I'll pass it forward to Tomislav.
Thanks, Monty. That's fantastic. You can see how much, if we had have had these recommendations right at the beginning in the early part of this year, we would have been much better prepared and would not be scrambling. And I think our clients would have been so much better off. So thank you again for that. So as you can see in the presentations, the first presentation from Monty was, what could we do immediately to mitigate the risk of COVID-19 to this vulnerable population? But at the same time, what do we do in the long term? How do we prevent individuals from being at risk going ahead? So what is some of the longer term strategies that we need to put in place now that would reduce the vulnerability of this community? And so Tomislav Svoboda is an associate professor, family physician, public health specialist in the Department of Family Medicine at the University of Toronto. He's worked for a long, long period of time. We've known each other for probably 20 years now, working in the homeless community, he in Toronto and myself in Ottawa. And he's provided primary care-based mental health and addictions care for the homeless. And so his talk will be ending homelessness as an intervention for COVID-19 among those who are homeless. So Tomislav, I'll turn it over to you.
Yeah, thanks a lot, Jeff. And thanks to everyone for joining in, and thanks to the organizers for inviting me. So I think for all of us, as I think Steph and Monty and Jeff have all alluded to, you know, it became quite clear to us, and we were quite nervous when the pandemic was starting, because we just felt and immediately knew that the population that we work with would be particularly vulnerable to this pandemic, and that indeed it's vulnerable to pandemics in general. And so as we were working on these recommendations, I think it was clear to all of us as well that really the definitive intervention is in fact you know, housing people, as one of our colleagues, Aaron Orkin, likes to say. You know, walls and doors really is perhaps more important than you know, the masks and gowns. And so we felt that it was important to touch on this and you know, on this topic of ending homelessness, and that in fact it should even be, you know, in some ways like a key recommendation and a key thing that we all think about and make central in our considerations on managing certainly this pandemic, but also future pandemics, which is part of the motivation of this kind of conversation. This is an interesting slide. It just came out recently, just a couple of months ago, by Miyawaki and others, New York City, where they looked at influenza that was presenting in emerge rooms, and determining, you know, which individuals were homeless and which weren't, and what the relative proportion of folks who were homeless was who were getting influenza. And they found that, for instance, in the influenza pandemic, the H1N1, about 10 years ago, during that time, it was about 30-fold. So folks that were homeless came down with influenza through the data that they collected 30 times more often than the general population. And indeed, you know, Steph and others did a study that just came out recently in the last month or so that showed that in long-term care facilities, the incidence of COVID was like 60 times the general population, and that in the homeless population in shelters was on the order of 20 times. And these are all underestimates. The 30-fold of H1N1 and the 20-fold. These are undercounts because we don't have good ways of detecting folks who are homeless. We don't record that very accurately, and indeed, you know, through casual contact, you know, there's many other conditions, as Steph pointed out. You know, TB is between, you know, 40 and, you know, 400 times. You know, there's a recent meta-analysis that came out, and you know, between I think it was 30 and, you know, 350 times the general population you know, incidence and prevalence of TB. And similarly, as others have alluded, others like invasive group A strep or invasive pneumococcal disease, you know, these are all conditions that can be contracted through casual contact, and all of these have been shown to be increased in the homeless population. And you know, all authors agree, all, you know, researchers agree that the most, you know, the almost certain cause for all of this is transmission within congregate settings. And so, you know, the question that, you know, that begs to be asked is, you know, should we not be, you know, ending homelessness? Should we not be housing people as a proper intervention, as the definitive intervention? And then there's also the question, you know, whether there's an upper limit to what we can achieve with infection control. I mean, if you look at, you know, long-term care facilities, I mean, we're now colleagues of ours, I guess in the Royal Society even, are presenting about, what can be done better in nursing homes and long-term care facilities, because clearly they're being hit very hard. And they have medical staff, they have infection control staff, they have regulatory framework that imposes standards, accreditation, infection control training is like a routine part of their culture, and they have like lots of experience. And Steph pointed out, the literature is certainly broader there, but they also have annual experience in managing outbreaks. They have enteric outbreaks, they have influenza outbreaks. This is regular procedure in long-term care facilities, and this is all new for homeless. For every one of these points, you could say not applicable in the shelter setting, or it's very rare. There's places where Steph and myself and Jeff and Monty work where there are some medical staff. We've probably started to develop kind of some sort of infrastructure where we're somewhat better prepared for some of this. But ultimately, the question is there an upper ceiling to what we can achieve? And would it in fact be more effective and efficient if in the long term, as Jeff suggested, and perhaps not even in the not so long term, perhaps even as this outbreak is progressing, that we begin to house people. And in fact, that is what we're doing. We're housing people temporarily in hotels. But then there's talk of those people that are in hotels not returning to homelessness, but rather being housed. And I think these are very, very important conversations that we all need to press forward. As Jeff kind of alluded to, this is just like a repeat slide. The Canadian definition of homelessness is the lack or the means of acquiring stable, permanent, and appropriate housing. There's certainly a lot of homelessness in Canada, but there's also a very small amount of homelessness on the other hand. When we think about ending a problem that's like affecting 0.7% of us, but is so visible, I think it begs us to do something about it. That something as fundamental as housing is something that we should be addressing. All of us, in medical school are taught the determinants of health, and certainly housing is one of them. And it just seems just inherently wrong that we continue to have homelessness. And Jeff pointed out some of the causes for that. So I think it's important to look at some of the structural causes, because when we talk about ending homelessness, some of us kind of say, is that like ending war, or is that like ending poverty? Is this something that's like kind of an apple pie statement that can never be achieved, or is it something that can actually be done? And so I'm gonna touch very lightly on this topic, but those who have done a lot of work in this area basically summarize homelessness as being caused by two things: not enough income and a shortage of housing. That's the predominant cause of homelessness. Probably like 80 to 90% of homelessness is caused by that. And then the next part is also to some extent the lack of sufficient supports, and in some cases actually non-existent supports. So Jeff and I and others work with folks who are chronically homeless and clearly have conditions that we have not addressed as a society. Complexity, concurrent disorders, addictions, and mental health that present themselves in such a way that we just don't have the programs. And I'll show you where there's some indirect evidence of that. And I would say, and this is almost like tongue-in-cheek, but the lack of programs is it seems like a tongue-in-cheek thing, but it's actually quite real. As Jeff pointed out, the discontinuation of some of our housing programs nationally have resulted in housing. And how is this possible? Like if you just look at Toronto, for example, there's if you make minimum wage, 15 bucks an hour, which is just recently the minimum wage in Ontario, that's about $30,000 a year. It's considered affordable if you pay $750 rent. And there's about 122,000 people or households in Toronto that for whom 750 would be affordable, but there's only 31,000 units. So, you know, 3/4 of the people don't have affordable housing, like it just doesn't exist. And it actually turns out to be 1 in 7. So 1 unit for 7 individuals, if you take into consideration that about half of the units that are affordable at 750 are occupied by people who actually could afford more. And then, you know, this slide here, the available social housing, shows how the ongoing development and building of affordable housing and supportive housing has actually been discontinued for the last 20 years, 25 years. And so there's a deficit of probably about 45,000 in Toronto. And then the wait lists are huge. So just as many people that are in supportive housing or social housing are in the waiting list. And that's continuing to grow. The longer we don't have a program, the more people will be on these waiting lists. And the waiting lists are like 10 years long. So, you know, as Steph pointed out, there aren't very many studies looking at, you know, what we can do for infectious disease, but we actually have done quite a bit of research on housing first. And we actually now have 15 good, you know, high quality studies. A recent review done by some of our colleagues have identified 15 kind of high quality studies, most of them randomized control trials, showing that housing first actually works, that stable housing is improved through housing programs. So the biggest one by far, 1,200 people, 110 million, you know, the Mental Health Commission funded this, and across 5 cities, found that over 2 years, 3/4 of people were housed versus 41% of people who weren't, 41% of people that were housed in the control group in treatment as usual. And this benefit extended to 6 years. So of course, we wait long enough, people will eventually, you know, get housed, many people, but there is a core group, as I alluded to earlier. There is a subgroup. So for instance, at 2 years, a lot of folks, about 25% weren't housed. And a lot of these people that were in this trial and in others were folks that were identified as high needs. A meta-analysis that recently came out also looked at income supports, and both income supports and housing interventions have been looked at through RCTs. And there's growing body of evidence. It's still inconsistent in a bunch of ways. It's consistent with respect to stably housing people. What's inconsistent is, I would say, the interventions. Like, there are many different styles of housing first that have been tried, many different environments. I mean, the at-home study was one that was multi-center, so I think it has a lot more strength. But a lot of studies showed different impacts with respect to reductions in emergency room visits, hospitalizations, improvements in mental health, reductions in shelter use, a whole variety of improvements that have been found. So how do we approach this? Again, I think we need a plan. You know, the Canadian Alliance to End Homelessness that many of us are participating in through our communities or as leaders in this area actually came out with a report suggesting that over 10 years, a $52 billion investment, or about $5 billion a year, which is actually a fraction of what we spend right now, which is you know, on the order of something like $7 billion a year nationally on homelessness through various shelter and emergency kind of services, could actually end homelessness. And when we think about ending homelessness, it's not just providing housing at $40 a day, as kind of described in the at-home study, which would actually come out to about $500 million per year. You know, there's immediately folks who would take up any residences that were built. As we showed, there's those 10-year waiting lists. There's 3/4 of people that are require affordable housing that don't have it. There's you know, 300,000 people in Canada that have core need of housing, meaning that they're either paying too much, or they don't have enough bedrooms, or their housing need major improvements. So there's a huge need. And you know, interestingly, in the last month and 2 years ago, the federal government came out with a national housing strategy, and there's a press release that came out in October that showed that the national housing strategy was $56 billion. And I thought, wow, perfect. You know, like, that's finally we've arrived. You know, we have this strategy. But it turns out if you look at the proposal more carefully, the Parliamentary Budget Office, even our own federal government, showed that only $11 billion of that 56 billion is actually new. 2 billion is on homelessness, and in fact, the 2 billion spent on homelessness is probably about 4% of current spending provincially and municipally. So in fact, the strategy is quite insufficient. And a lot of the homes that are called affordable are actually affordable by some definitions, but by the definition that, you know, I kind of alluded to earlier, people needing housing stock that's less than $750 per month, there's actually very little of it. It turns out that the definitions of affordable housing exceed certainly folks who are homeless, what they can afford, and many of the people that are in waiting lists for affordable housing. So the Canadian Alliance actually suggests an additional 52 billion in addition to what in reality is 10 billion to end homelessness. And I think we should actually be, you know, exploring this. And so I give some of those caveats as, you know, as a warning for all of us when we see some of these strategies, that we actually probably need a program rather than a strategy and a plan, and that it needs to be targeted and directed at those folks who are homeless. So I'll end it at that. Thank you.
So thank you, Tomislav. That was wonderful too. That they, you know, I think your definition of those people who are currently experience homelessness, you know, the people who are either poor and lacking resources or have underlying medical challenges that prevent them from getting access and reasonable health services to allow them to move into a more stable environment. It's a way of thinking that some we can move directly, as you've always pointed out. We can always take those people right now. If we had access to housing, they could move immediately. Others, we would have to move with supportive housing, where we could provide those necessary services in a more stable environment. Because as all of us know, trying to deal with somebody's addiction, mental health issues, their physical health challenges in the chaos of a shelter environment is almost impossible. So thank you. So I'm not seeing any suggestions in the chat, so I'd encourage people to use that. But in the interim, I'd like something that's bothered me or not bothered me, I think I should be very happy about it, but why is it, I'd love to put this to the panelists, why is it you think that we have not seen the morbidity and mortality that you would expect that we saw in long-term care facilities? We've all had outbreaks. Our isolation unit has a dozen so people today. What is it? Why is it that it has not overwhelmed us? Is it because we were really good and smart and done all the things that Mondi wanted us to do? Or what was it?
I mean, I'll jump in. So, I mean, I think, you know, part of this is that like mortality so I'd say this, that like, I think the outbreak potential is high within shelter settings, and that we saw in Toronto, that there was as Tomislav noted, it was about over 19 times increased risk of getting COVID if you're living within a shelter setting. So there's definitely been outbreaks. I do think that like, you know, similar to folks outside of congregate living settings, or outside of shelters, is that there's the mortality really varies based on age and comorbidities and things. And you know, people have used a number like 1,000-fold difference, you know, between sort of younger folks and older folks. I will say that like where I've been working, and Tomislav knows this, like the only reason I got involved was just to protect Scarborough Village residents, always from day one, because it is a place where people are really quite unwell, and an outbreak there. And we just had a massive outreach testing and 0 infections. So it's just to say that an outbreak there could change those statistics immediately. Like one bad outbreak with a tremendous amount of mortality could change, you know, the sort of comparisons of mortality and the statistics around mortality in a very quick way. So I do think in some ways that there's been a tremendous amount of interventions, all of us across the country and whether folks who are sleeping rough, sleeping within shelter settings, et cetera. There's been a lot of work to try to prevent outbreaks. But I think especially so in the places where people are really, marginalized. And so as Monty talked about, like staff cohorting, staff PPE, all of those things happened. And also just sort of like decongesting the really high risk shelters. And by high risk, I generally mean where folks are older or have, really significant comorbidities that put them at risk for mortality. So I'd say that I don't think that there have been outbreaks, but I would just say in general, those outbreaks have happened in shelters where there's younger folks, otherwise more healthier folks, and there just hasn't been the same level of mortality associated with those, thankfully. I mean, I was, say that with incredible, but there is also that idea of the counterfactuals of just a lot, the cities need to be commended, the staff at these facilities need to be commended because they've stepped up to protect their residents in a way that I think is really telling. And to get to that last step to prevent the outbreaks, while the shelters and the city employees get paid leave, I just have to say this, that like all the agency hires and contract hires, which make up sometimes as many as like half the people working there, do not. And, WSIB and others have been using that's the Ontario, obviously, Workers' Compensation Board, uses very funny rules in terms of who gets paid leave or not. So I think it's like at this point, the facility-based interventions are key, but we still have structural challenges that really limit our ability to really protect folks across the board. And I think, and so I'll stop there.
Yeah, I mean, just to add to what Stefan had mentioned, that's a great question that we ask ourselves all the time. We've had over 60 positive cases in Alberta within this population group, and we've actually had really good outcomes with all of them, and we don't know why. So despite the fact that there's a greater prevalence of uncontrolled cardiovascular risk factors in this population group, despite that there's a higher risk of immunosuppression secondary to HIV, Hep C, opioid use, we can explain why this population group has had less negative outcomes. And there was a prediction model that was done at UCLA this year that sort of estimated that this population group is at 2 to 3 times higher risk of mortality compared to the baseline population. And again, very, very surprising. And amongst the shelter workers and people I work with, we joke around that our population is so acclimatized to having poor health outcomes that they're just resilient. They just do well. And we have no other way to explain it. I mean, they often get the flu, they deal with poor sanitary conditions, yet they're resilient. So someone needs to do a study on this sometime in the future.
Tomislav, any thoughts?
Yeah, all of the above. I think back to basics. Agent, host, environment. There's probably environmental factors. I mean, Steph kind of touched on it. There's things that we did. I think we did well. We didn't fast. Sometimes it felt like just under the wire. I mean, I think Steph runs a super tight ship over at SVR, and I think that they haven't had an outbreak is a testament to that whole team there and him being there. And there's host factors like Monty kind of alluded to. And it could be anything from the like he pointed out, all sorts of exposures that have built some resistance. I mean, there's even talk and some evidence suggesting that smoking, for instance, might be protective. There's all sorts of host specific things that could be kind of protective. But again, we have had outbreaks. As of I think beginning of August, we had like 800 cases in Toronto. We probably have a lot more now, and yeah, we were expecting, we did some modeling. We're expecting a lot more mortality, but again, we need to think about, not just now with COVID and how things can happen in the next wave, but also for future pandemics. We've been thinking. I was around during SARS. I mean, I feel somewhat embarrassed because, I've been thinking about other things, including, I guess, to some extent, as all of us have, on ending homelessness. But yeah, this kind of came as a surprise, and I don't think we can do that again. And I think, we have plans of ending homelessness potentially in the next 10 years, and I think we should really do it.
Thank you. Let me just ask one other question. What has struck me as fascinating, and it reflects a little bit your presentation, Tomislav, that when we knew we had a crisis emerging in January, February, we had people volunteering to come and help us, give us money. We went to a community center, and within probably 3 days, we turned that community center into a isolation center equipped with oxygen rooms. You know, it was a medical facility. The floors had been taken out, everything. Housing was there. Hotels were offering spaces. People were making gowns for us. Masks were being donated. We had everything. And we were able to respond dramatically to, we had an isolation facility, we had decanting procedures, cohorting procedures, we had a coordination network, we were working with public health, etc. And then, you know, we have the other alternative of what you're talking about, Thomas Love, is ending homelessness. And it seems we have a cost-effective strategy to do this, saves money, we can't afford not to do it. Why do we have this disconnect, you know, between, you know, everybody saying, yeah, let's solve this problem? And I think it's important to think about it, because can there be something good that comes out of COVID-19?
Yeah, you know, in the cost effectiveness studies that that were reviewed, you know, I mean, people were making these comments that that in fact it's just something that, you know, we have to do. We just have to, you know, it's really up to the payer to decide, the society to decide if this is something that they want to do. And I think what your story actually clearly demonstrates is that people do want to do something and do want this to end, and that it's fairly universal. And I think it crosses, you know, all party lines. I think is that we need to do this. And you know, we've been talking about ending homelessness for 20 years. There have been, you know, plans, you know, across, you know, all the major cities in Canada over the last, you know, 15 years. And now we have this, you know, national housing strategy. You know, it's actually peanuts. It's, you know, it's about, you know, $140 per capita to end homelessness per year. And we spend, you know, about $7,500, $7,500 on healthcare. It's about 40 cents a day. Like it's actually really cheap. And it's just something that I think we have to do. And because it's just coming back to bite us every time. And, you know, and Steph, I think is much, you know, this is his area of study, but, you know, I've come to appreciate how a lot of this transmission happens in networks, you know, more vulnerable networks. And certainly the homeless community represents one such network. And indeed, that's the solution is actually, you know, homing in on the communities where this transmission is going to happen no matter what. No matter how good our PPE and our IPAC is, it's just going to happen. And you know, we need to do that analysis, even economic. I mean, you know, this will just be another huge amount of money that we've spent for this population. That's completely inappropriate. I mean, I think it just has to be done. And $50 billion sounds like a lot. I think you know, over 10 years, it's actually peanuts. So I think we need to appreciate that.
Thanks, Thomas Love. Rachel had a question for Monty. Did you get a chance to answer that, Monty?
I did, yeah. I answered in the chat, and I guess we've only got a minute left. So, but in brief, Rachel was just asking about the recommendations and how difficult they were to implement. They are difficult to implement in Alberta. We don't have all the resources to implement them, but we're moving towards implementing them.
Okay, as Monty said, our time is done, and what I'd like to do is especially thank the panelists for all of their hard work as part of a broader national group, but they have done a lot of the heavy lifting. So special thanks to them. Special thanks to all of you who are participating today. And if you have any comments that you'd like to send to us, we are certainly available and would love to hear them. We'd love to answer any further questions, but comments about where we're going would be well appreciated. hearing no other concerns, and I don't see our other panelists sort of going like this, then I think I'll say thank you very much and wishing you all a good day. Bye now.
Thanks, Jeff.